Hi, good morning, everyone joining us. I'm Dr. Dan. I'm an emergency physician by trade, a former Obama administration biodefense and public health appointee. Glad to be joined by my wonderful colleagues, Dr. Matt Kushner and Helen Arteaga. They'll introduce themselves and I'll let them introduce themselves, but we're here to talk about flu and COVID in 2023. Happy New Year to everyone. And of course, we still have lots of viruses hanging around and everybody wants to shine. So with this opportunity that we have through NMQF and our other partners, we're going to have a fruitful discussion, lively discussion, giving you ground truths, clinical expertise. I mean, my colleagues here have been doing this for a while and literally engage with people on the grassroots level, but also have the high level and the knowledge, of course, to help dispel any myths and also educate us on what we need to talk about. And I think this should be a fruitful conversation. So with that, I'm going to pass that on to Dr. Matt. Can you introduce yourself? And then to Helen.
Good morning, Dr. Dan. My name is Dr. Matthew Kusher. I am the Clinical Director of Plaza Family Health Center, a part of Urban Health Plan in Corona, Queens, New York. And I'm a family physician by trade and have been fighting COVID and flu since I can remember now. I still live in 2020. I'm going to pass the mic over to Helen.
Good morning, everyone. I'm Helen Arteaga Landaverde. I am the proud and humble CEO here at Health and Hospital Elmhurst. We are a level 1 trauma hospital. We have 545 beds. We're actually the biggest hospital in Queens. And we also sit in the most diverse district, not only of New York City or New York State, but actually the nation. And sadly, we were the epicenter of the epicenter. And it doesn't matter which wave hits us, our community, sadly, we have the highest numbers of COVID, flu, and RSV currently. So much like Matt, I'm still living in 2020.
Yeah, I think I'm living in 2022. I'm going to join you all. With that, I want to make sure we pass it on to our colleagues who are kind of putting this all together, do a quick introduction of NMQF and what we are, and then we'll dive into the conversation.
Well, thank you so much, all of you. A happy New Year's, everyone. It's really an honor to work with these amazing health champions and to really focus on a subject that I think needs more and more focus. I am the president and founder of the Center for Sustainable Healthcare Quality and Equity, SHC, which is part of the National Minority Quality Forum.
Thank you so much, Laura Lee. We're glad to have you and the wonderful team that keeps all of us together. So without further ado, let's dive into some of the issues that really are ongoing here. And if you're tuning in and just joining us, you'll see these slides. We'll kind of break down. We're going to be talking about flu and SARS-CoV-2 infection, and all other viruses, and where we are. So if we look at this slide, the first slide is, this is all CDC data. So you can go to cdc.gov. You can get some of this information. What we've been seeing is that there's increase in flu activity, obviously, but predominantly it's the H3N2 subtype. And what we're also seeing is that over all the cases that we've seen at least a total of 61 pediatric flu deaths so far this year, and that's at least reported in this week. Now, when you look over the time period of what the cases and how these cases have risen, we've seen at least 20 million illnesses, 210,000 hospitalizations, and increasing, by the way, and 13,000 deaths. By the way, typically flu season can be anywhere from 30 to 60,000 deaths a year. So when we look at the totality, the season is not over, obviously, so all the numbers aren't in, but that's just something to keep our awareness. Next slide, please. So on this slide, if you hopefully not colorblind, you can see through the different colors. And really the moral of the story on this slide is basically that we're seeing very high to very high activity of influenza across the nation. And the areas where it's a little bit green or lighter green are seeing minimal activity. But for the most part on the map, it's high to very high. Next slide, please. And when we look at disparities, because we do talk about health equity and racial disparities a lot, and it's important as the impact on healthcare, you can see the range in terms of disparities with flu vaccine coverage. And this is the same thing for adults and same things for children. We put the adult slide here, but reflected similarly with regards to children. What we do see is that from 12.2 to 26% points, or at least percentage, in terms of the higher rates within non-Hispanic populations. That's what we're seeing. But when you look at it overall, our white adults seem to have more uptake or access and coverage with regards to flu. So that's the number, the 45.1. For Hispanics, non-Hispanics, they seem to have the lower end of that population or percentage, which is about 12 to 26.1 in range. And when you look at African Americans or Blacks, non-Hispanic Blacks, it's about 25%, 28% within those areas. For Black population specifically, 32.9%. What does all this mean? It means that there's a disparity in those who get vaccinated, and that's why we see a lot of patients in that same population being hospitalized more. Next slide, please. So looking at the coverage for this season, as of December 3, this is the latest data. You can see again, Black children are about 38.3% were covered, and with Hispanic white children, non-Hispanic white children, 46%. Again, this is the disparity we've been talking about. When you look at for Hispanic children, in terms of their coverage, it's about 47.6% compared with a previous number, which was 41%. So a little bit of an uptick there. Next slide, please. So when we look at the COVID cases weekly and death, the moral of the story is, at least when you look at it and look at the graphing, it seems like the Hispanic population has an overwhelmingly increased number over time of death, basically looking at this data. So that's the graph right here. It has definitely been an increase, and you can see the color-coded graph. So that's that green graph with that spike right there. But over the periods, you can see over the years, it varied, but there's a higher peak at this time. Next slide. And this basically looks at the percent of people receiving vaccine, again, administered over time with regards to the bivalent vaccine. This is the latest vaccine that we have in terms of uptake, and this is the breakdown based on population and race within the area. So again, you still see the same disparities with about 15%, 15.2 or so percent in the white non-Hispanic population, and then in the Hispanic population, 7.2, and in the Black non-Hispanic, it's about 7.9. Again, disparities are being consistent. And next slide. And this is just a snapshot looking over to where Helen's neighborhood is. You can see that in the Queens area, the vaccination rate average right now is about 10% in terms of coverage with the bivalent booster vaccine. But overall, the range is 6.5 to 24.3%. So that's just a snapshot, which will set us up for some of these conversations about what we need to worry about and what's really going on. So without further ado, so I'll pass it on to Helen. Helen, so tell us, what are you seeing as an executive? You get to know you have your finger on the pulse, you know what's going on within the community, and you also have to make tough decisions and figuring out what the next steps are. So what are you seeing, and give us your perspective, not only the 30,000 foot view, but also what you're seeing on the ground, and what leaders like yourself should be thinking about as we're responding to these things.
I think, sadly, we thought, we hoped that the community had this awareness and vaccine hesitancy had decreased. But sadly, that was very short-lived, because I think when we look at fully vaccinated individuals, Queens had the highest rate, with a lot of work that we did to demystify, about the vaccine and vaccine hesitancy. I know Kusher and I worked a lot together in, doing informational work, town halls, workshops, being in the media, being with community organizations, religious organizations, saying, hey, the vaccine is safe. and it's important to keep you out of the hospital. And here comes the booster and the worst flu season ever. And we think like, oh, we did all this work. People are going to come for their booster. We got ready to, manage long lines, manage the supply, manage the nurses. We got additional staff for our vaccine center. And we were all ready and no one came, sadly. As you saw, our percentage here for our borough is around 10%. And it was very sadly, we were like, the vaccine hesitancy is still there, even though we had all these lessons learned and all this work done during the first wave of the vaccine of COVID, the first round of the COVID vaccine. So it was very sad to see that, again, this vaccine hesitancy on the booster was now born. We saw people like distrust the booster. We saw a lot of misinformation again was born. Twitter and TikTok started saying, oh, you don't need the booster. You're not going to die. It's all myth. They just want to, give you more injections. And again, we started seeing the issue of, well, I don't have time. It's not convenient for me. And then we had to re-educate the staff on why this booster, especially the bivariant, was so important, because we had just suffered Omicron. And here at the hospital, Omicron was crazy. It was like COVID part 2, because not only was it affecting everyone in the community, but it was affecting our staff as well. We had shortages of everyone because it was so contagious. It was even more contagious than the first wave. And the hospital was full. We didn't have enough staff. So we thought like, okay, the booster's not here. It's going to help us. But yet the uptake on the booster was not enough. And then when you hit that with a strong flu season, getting individuals to get their flu shot was even hard as well. And then we saw vaccine hesitancy on the influenza vaccine.
Sure.
So we were trying to fight this battle in both directions, both for the booster and for the flu vaccine. And then when we bring it down to the community level and that one-to-one with the patient, I think the biggest thing that I think we did really well here at Elmhurst, especially when it comes to our employees, because around 47% of our employees are now have their booster and their flu vaccine, was just education, the peer-to-peer. And we also had a flu fairy.
Flu fairy.
Yeah, with wings and everything.
Okay.
Come to the units and really say, hey, you could use the flu vaccine. Let's keep each other safe. Just because we're seeing, between the flu, COVID, and RSV, sadly, Elmhurst, in our health system, we have the majority of the patients.
Wow.
So we're trying to attack it at all different levels.
Well, thank you. That gives us some great insight, both from the high level and the ground level. Dr. Kusher, what are you seeing, and what's going on on your side of things?
Well, sadly, I don't think that the booster uptake has been that much of a surprise. And the reason I say that is because every additional vaccination we have added from the initial 2 doses, we have seen a reduction in the uptake. So we're talking about the first booster, but then the second booster, there was a significant reduction across the board, not just in the Latino and Hispanic community, but across the board, across this country, a reduction in the uptake of the vaccination. And that is related to vaccine fatigue, not just vaccine hesitancy, but vaccine fatigue. People were just tired of getting injections. And people are used to getting a flu shot every year. And it's just become more commonplace, which is why I think we see higher levels of flu vaccine uptake versus COVID. And to this point, COVID is almost like a yearly injection, but yet we don't see the same numbers. And that's because people got accustomed to getting a flu shot. And yes, we still have some of that flu vaccine hesitancy, but the COVID one is different. And I think we almost, unfortunately, kind of shot ourselves in the foot a little bit with the way that we had the 2 boosters in terms of COVID, just because people did become vaccine fatigued. And I think that's the best way that I can describe it, because I see it among my staff. So and we are the same patients as Helen. And so we have seen the same surge of people being ill.
So how do we kind of, and thank you for that. How do we kind of get around that? Like, so there was there was guidance on having the flu vaccine and the COVID vaccine at the same time. Do you think, excuse me, do you think that was useful?
We've known that guidance for a while, that you could do that. I think that people were not interested in taking 2 vaccinations. I think by next year, we're going to have a combined, my hope is we will have a combined flu COVID vaccine that'll be in 1 injection, and then people just suck it up and do it. But the idea that they have to, in their minds, suffer through 2 at the same time, I don't think it was going to happen. And I don't recall any of my staff actually going through with it and getting both at the same time. Maybe Helen's Ferry gave them that, but we certainly, I don't recall any of my staff or any patients really willing to. Maybe some of the older folks, you know, above 65, above 70 years old, they were like, okay, fine, I'll do both at the same time. But people that needed to work, they were not going to do it. They did not want to be that sick and then they have to not be able to go to work.
Yeah, I never
Just to
liked
jump off on, just want to go back to what Helen was saying before, just quickly, Helen. I think access is still an issue, and I think access, you know, as much as we've tried, and I understand that Helen had this big clinic, I still think at the end of the day, access is still an issue, especially around flu vaccines. Flu vaccine is not free like the COVID vaccine is, and I think there is still access issues. I think there's a reason why the children in the Latino community have a higher rate of the flu vaccine, because it's free. And that is not necessarily the case for the flu vaccine for your adult patients who are either uninsured or underinsured, many of them, especially what we see.
Yeah, that sounds very interesting. And I think also I'll give credit to the Academy of Pediatrics and the pediatricians in the community also. They put this in their schedule with the vaccination to emphasize that. And I think also people have seen what was going along with RSV, and they were kind of like, okay, I got to do everything I need to do for my kids. In addition to the fact that you said, you know, the highlight that it is free. So even I had that same issue. I couldn't get an appointment with my doctor. I had to go to the local pharmacy and pay out of pocket. I had to deal with insurance stuff. So you can see some of the reasons. We're not making excuses for people. I think you just work around it. Once you've had the flu for real, in your real life, I think it changes people's behavior. At least it did for me. I don't like that feeling of being prostrated and laying down in body aches and crying like a little baby. But with that, Helen, you wanted to add something in there. I'm sorry.
First, Dr. Dead, I don't see you crying anywhere.
Oh yeah, the flu is no joke. I did. I can definitely say I did.
You look like a strong guy. No, I think, you know, I agree with Kusher. I think one of the biggest issue is access in our community. And for us here at Elmhurst, one of the things we give out the flu vaccine to our communities for free. And just getting the word out there that it is free, you know, was hard because people are like, why is it free? You know, and again, it goes back to that hesitancy of not trusting the government for some odd reason. And sadly, do you blame the immigrant community and the communities of color when we've had so much racial distress, both politically and socially? I think them trusting government is going to take a while. And, you know, Elmhurst Hospital, we're a public system. And I think when we say, hey, we have something for free, people are like, why? You want my data, you want my information. And we have to go into like, understand where they're coming from and say, no, our stuff, we never give it out to immigration. We never give it to the government. It's just to track that we make sure that you are up to date in your vaccines. That's it. If you ever want a copy or a letter or anything saying that you got your vaccine, we're here for you. But I think the biggest thing that I think any organization or CBO or clinicians could do is not judge. I think one of the big successes that we had here at Elmhurst in getting individuals vaccinated, both employees and our community members, is meeting them where they're at. We've heard some interesting things about the vaccine and just being like, okay, I see where you got that information, but let me tell you the science. Let me prove to you that that information is wrong. And some of it is so out there that you're like, okay, that's fine that you believe that, but let me tell you the benefits anyway of taking the vaccine. I still get people like, oh, you know, I still have I can put a quarter and I'm still magnetic. And instead of saying, well, show me, we're like, okay, We understand where you're coming from, but let me explain to you the benefits of getting the booster, of getting your flu shot.
You got to admit that some of these
community is number one.
You got to admit that some of these
Oh.
myths are funny and interesting, and I like the fact that you say we should have empathy, we should understand and not judge, and that's what they come to us for. It's a big message for all the clinicians out there, and for the patients who are just concerned and have doubts. You don't want to be ridiculed. We get that, and I think it's important as a big important message. What are some of the other things you all are seeing, Dr. Matt, that you think we should be addressing, especially when it comes not just around the myths and the hesitancy, but how we continue the engagement within the different communities, especially looking at the stats and the data that we've talked about, and as we're looking forward to how we respond. Is there something else you mentioned about the cost and access? Helen has a different perspective, or at least experience on her side, where it's actually free, but there's still hesitancy. Is there something else we should be doing, or any ideas or thoughts?
I think we need to, what you guys were talking about, just acknowledge people's concern, acknowledge that the vaccines do have side effects, because they do, right? Both the flu vaccine and the COVID vaccine have side effects. Those side effects are real. Not all of the ones about magnetism and microchips and things along that nature are real, but there are real side effects. People really do feel unwell. Mm-hmm. Not everybody, but a lot of people feel unwell when they get the vaccine. And there are some people who have long-term side effects, GBS, which can happen with the flu vaccine, can happen with the COVID vaccine. These things really do happen. So I think it's worthwhile that we need to acknowledge that that's the case, while also saying, but you can also get myocarditis. You can also get myositis. You can also get all of these other things, including GPS, from the virus itself. And it's more likely.
So sorry, I want to stop you there. Can you explain that to us, what that is? What is GBS and what is myocarditis?
So GBS is Guillain-Barré syndrome, and it is a syndrome where it's an autoimmune effect where your body attacks your nervous system. And it is a known thing to happen with flu vaccine. It can happen with COVID vaccine, but it also can happen with viruses.
Exactly, like which is a great point. Yeah, it's an awesome point.
So what we need to acknowledge is that and the myocarditis is an inflammation of the heart and inflammation of the bag around the heart that can happen, which was a big concern in younger people who are getting the COVID vaccine. But when you look at the data, that does happen with the vaccine, but it also happens with the virus itself.
Actually, more times with the virus. More
likely to happen with the virus than with the vaccine.
Correct.
So I think having an open, honest conversation about the fact that these things do happen, it's true. But then it's also true that the virus causes more side effects than the vaccine does. And that's my pitch always with patients is we need to weigh the side effects. There's side effects of the vaccine, there's side effects of the virus. But at the end of the day, the side effects of the vaccine is less than the side effects of the virus. Correct. The virus has more side effects overall that you might not read about on the internet because anti-vaxxers aren't putting it out. But these are the realities that are happening, and we just need to be aware of that. So that's one part of it. And the other part of it is making sure that we can make it easy for people to get the vaccine. People can come into our health centers, they can come into Helen without an appointment to go get their vaccination, whether it's a COVID shot or a flu vaccine. They don't have to figure out a way to register online or give all their information online like that. And people are concerned about doing that. So they can just come in. They're already a patient for a flu vaccine. They can just get their vaccine there and then. If they're not a patient, they want a COVID vaccine, they can just get their COVID vaccine. We try to reduce the number of barriers and obstructions that we put up, because there's a lot of systemic barriers and obstructions for people whose health literacy, regular literacy, technological access is reduced. So that's what happened with the first round of vaccinations. We're talking about now last, I guess 2021, right? 2021, the spring of 2021, when everybody was getting their vaccinations, and we had all of these obstructions that led to a decrease of access. And we're still working on trying to help make sure that we have less obstructions so that people are able to come in. And then we can have these sort of discussions about why it is still important to do these things and why the side effects of the viruses are clearly much worse than the side effects of the vaccines.
Well, thank you for explaining that. I think that's important. I think there are other things we also should mention with regards to not just side effects, but also complications. So maybe we want to go into the complications that people can see or experience with the virus, having the flu themselves, and as a rationale for why get the vaccine. Any thoughts, Helen or Dr. Kush?
You know, I agree with Dr. Kusher 100% on the two items they said, but I would add the third piece, and it comes to the risk and all the amazing data that you presented. I think communities of color need to understand that the risk of not taking the vaccine ends up them being ill, so ill that they could end up here at the hospital. If you're Black or Latino, you're 4 times likelihood if you get the flu to end up in my ICU. 4 times likelihood. You know, I still think, and COVID was horrible, but when I think of like flu, it's such a preventable illness that we can do. And to have our community suffer so much. And, you know, you presented some numbers that, you know, Black and our non-white population, you know, the likelihood of us getting the full flu and COVID, and it's like twice as much as the white community. And why is that? Is it because of access issues? Well, fine, let's fix the access issue. But I also think the other thing is we have to understand as a communities of color that we are just higher risk. Doesn't mean we're less equipped or, you know, we're less, I don't know how to say it, but we're less fit to fight a disease. You know, we're all human beings regardless of our race. But I just feel our bodies, for some apparent reason, you know, we don't do well with these type of respiratory diseases and viruses. So here's the vaccine. Why are we not taking it? And I think part of it is we don't understand the risk. And when the risk is, you know, I'm 4 times likelihood to end up in the ICU. Mm-hmm. I'm gonna, you know, that's my reason to take the flu vaccine. I don't want, you know, even though I work at my hospital, I don't want to end up in my
we expect the vaccines to do, Helen. We need to change what we expect them to do. Our expectations that the vaccine is going to prevent us from being ill is not so good, right? We learned that with COVID right away. It's not meant to keep us from getting ill. It's meant to keep us out of your hospital and to keep us from dying. That is really the end result. And that's the thing we don't talk about as much because people say, well, why should I get a vaccine if I still get sick?
Right.
Well, if you didn't end up in the hospital, you didn't end up dying, right? So therein lies a reason that's important.
Yes.
Because being hospitalized, as you pointed out, Helen, is not rainbows and butterflies. It is sitting in the hospital, is being poked and prodded on monitors, feeling like garbage. And then afterwards, you still feel yucky even when you go home. It's not as though, oh, I feel 100% when I walk out the hospital. No, you feel good enough that you can go home, but not good enough that you're going to go back to work, you know, or good enough that you're going to be able to take care of your kids, or take care of whatever it is that you need to do, your parents, etc. I think we need to reframe how we expect the vaccinations to do it, because I think a lot of times I hear, oh, well, I still got sick even though I got the vaccine. Yeah, you got sick, but you didn't die. You're still here. You're still in front of me. You're still sick, but I didn't hear about you having a new hospitalization, did you? No, because you did get the vaccine.
Yeah, no, I think that's such a great point, and it is important. So for those listening, this is where we talk about the vaccine is not a force field. It's more like a shield. I think it is important to make sure we temper expectations and educate. May not even say tempering expectations. It's actually educating people on what the expectations are, so that they understand why it's important. And I love how you said that. And yes, when you go in the hospital, I went for a procedure, and yes, I got the wonderful dignity of how a patient actually feels when they become, or how a doctor becomes a patient, and how I actually went through that whole process. And I actually shared that on my IG. When you get a second, check it out. It's colonoscopy. Anyway, I'm putting my business out there, but I think it is important for people to actually understand we are human, and we understand what it is to be a patient, and we have the concern and the love for our patients that we want to give you the information as best as we can, but also give you the reality. And I love that we're giving you ground level truth and actually practical stuff and the real stuff. Like there's no sugarcoating anything here. So let's
But Dr. Dan,
pivot.
can we get back to what Helen was saying in terms of the risks and why risks are higher for Black and brown
Yes,
people?
sure.
You know, the reality is that based on the structural racism and the other barriers that we put in, it is baked into the sauce of this country.
Correct.
We see higher comorbid conditions among Black and brown people. High blood pressure, diabetes, heart disease, you name it, those levels are all higher. And some of that is genetic in nature, and some of that is based on just the systemic racism and lack of access to other sorts of care that many of us have talked about, especially in the last few years, in terms of how COVID affected Black and brown communities, more so than affecting the majority population. And so it is not just about the color, it is about the comorbid conditions that are affecting the community, which gives people a greater risk of having an adverse outcome, an outcome which is really poor, whether it's hospitalization or death, because of viruses that some other person might be able to fight off better.
And so that, and a great point, and access to that information, education around that information, being able to understand why there should be uptake. And you saw the disparities earlier with regards to non-white population versus white populations. It was very clear. I think the other part that we need to talk about, I wanted to get into the complications and the other additional reasons why. So pneumonias, people can get pneumonias. One of the classic stories, if you hear a person, they had the flu or had a viral illness, and a week later they had gotten better, they resolved, and a week later they come on with a new cough, a new fever, some shortness of breath. Think pneumonia. It's one of our classic board questions as doctors. It's our bread and butter, but just be aware that they really need to go get checked. I think that's very important. Other things, we mentioned Guillain-Barré, which Dr. Kusher had described, that neurologic syndrome, but also later on, some people can get certain forms of encephalitis, basically inflammation in the brain, and they might lose some of their coordination, ability to speak, and also can lead to death and meningitis. So there are many other complications with this. We talked about the myocarditis, the inflammation around the heart, as Dr. Kusher had mentioned. So I think people need to keep all those things in perspective. It's not to scare you, but these are real things that we see day in, day out, and patients that present to us with that. Okay, so what other things do we need to talk about? Some of this, we've talked about structural issues and racism within the healthcare system. We've talked about the disparities. We've talked about access. We've talked about some of the myths, and dispelling that with compassion and understanding. But there are also some other issues. How do we get our populations to go get the vaccine, or at least to protect themselves? What other things can they do? And who are at risk? Is it elderly? Is it the young? Is it everybody? Go ahead, Helen.
I'm excited on that question. I was like, me, I know.
Yeah, sure.
No, I think why I get excited about your question is because we are the living example of what that answer to that question is. Yeah. I think how we really shift our community and get rid of some of the myths and really transform the communities that we're working on is partnership. I think, you're a physician, Plaza is an FQAC, I'm a hospital, I know Laura Lee's in this world somewhere with the Minority Council and Forum. I mean, I think groups like us getting together and saying, hey, we're very trusted in our communities. Let's sit together. Let's come up with ideas. Let's sit around and talk about these issues. What am I seeing? What is Kusher seeing? What are you seeing? What is Laura Lee seeing from behind the science and the research? I think that type of partnership really helps you brainstorm and think of innovative ideas, because I don't have all the answers. Kusher's very smart, but does he have all the answers either? And I think when we have these forums and we have these, even this Facebook Live thing, like I'm sitting here and I'm like, that's a good idea. I'm going to try that. And one idea can lead to another idea. And those little sparks can really transform our communities. Is that one little shift that can help another organization? I think one of the great works that we do in our communities, we work a lot with the barbershops in our council here, that we work together with Laura Lee and the team. I mean, we work with churches, I know Plaza del Sol is very grassroots. I mean, I think the stuff that we do when it comes with partnerships is so unique because we're really focused on how do we shift our communities to get healthier. And there's no a gotcha. We're not selling anything. We don't want anything from our community.
For free 99. Come on, we got you for free 99.
Yeah. Like,
but wait, there's more.
Yeah. So I think that's the answer to your question. Like, how do we move our communities forward? How do we address all these issues? And I think it's community leaders and community partnerships, and getting all the different players to sit around, whether in person or virtually, and getting some good innovative ideas of how we can get this done.
Totally agree. I appreciate that. Dr. Kusher?
So I agree with Helen. I think partnerships are important. One of the ways that we were able to increase our COVID vaccinations with the original primary series is when we partnered with the local Catholic Church, which was the biggest parish in the neighborhood. And Helen knows this well, she's a parishioner there, that it is, besides us, the Catholic Church is, of course, a very important institution in the community. And if they also are saying, hey, it'd be a good idea if you do the following, hearing it from more than one place does help people to say, fine, I'll do it. Because as I've always said, and Helen's heard this a million times, I don't need them to enthusiastically say, yes, I want it. As long as they say, okay, and wrap up their sleeve and just take the vaccine, it doesn't matter how enthusiastic somebody is, as long as they do it. So the more institutions that are trusted are saying the same message, it is more likely that people are going to go ahead with it. And I think that faith-based organizations are important players and important for us to be able to coordinate with, because people of faith believe what their faith leaders are telling them to a certain extent, right? Just like they believe what you and I are saying, Dr. Dan, right? They take it and they go with what
they're just some quacks. Yeah. They're just talking.
But when more than one person is saying it and they're saying the same thing in sort of the same sort of voice, it is more likely to help that light turn on. And I think that that's an important part of it, especially since, yes, America's in decline in terms of their religiosity, but in minority communities, there's still a large percentage of people who truly believe in religion and have faith. And I think being able to pick up and being able to partner with those sort of organizations, it does help us to move the needle.
Yeah, no, I think that's great points by both you and Helen. I would add also that, or what I'm hearing is, the connection within the community. But I think in addition to the faith-based organizations, to the barbershops, the innovative approaches through community, the cosmetologists, your local community leader, or other influencers, we pull all levers. And remember that those levers or those messengers also have to look and resemble that community. There's one thing that I found in the pandemic that during the COVID times with regards to what we call in research and science presentations, CSA compatibility or incompatibility. What does that mean? Basically, when you say something, but it's not on the slide. So the same thing when you say something from the community and you have somebody who's not of the community. And a classic example, somebody who wants to speak to a Hispanic community who's not Hispanic and you can't speak the language or have a command of Spanish, while your efforts are in the right place, that might not be the right messenger. And same thing with the Black community. So I think people need to also think about that. It's the real truth. There is colorism sometimes within communities, but it's who they're familiar with, who they're comfortable with. And that's why influencers get to do all certain things also, and behavior gets to change. So we're trying to get behavior change and thought process. And I think to reach people, we have to reach outside of those things. We also have some questions. So I'm going to read some questions and maybe Helen and Dr. Matt can comment on it. So one of the questions was, are there additional specific approaches or actions that you would suggest clinicians implement to best help Hispanic or Latina patients receive flu or COVID vaccine? So I'll throw that out. Anyone?
I think we need to realize that the way we speak about the flu vaccine is challenging because there's different words that we use for flu. And so people will say la gripe. La gripe is technically the flu, but people use it for the cold. And so there's actually a word for cold, it's resfriado, but nobody uses that. Very few, I should say, use that word for cold. Everybody uses gripe. So
I'm
when
gonna
you
add
say
that to my Spanish repertoire.
yeah, so we're using where we say, oh, es la vacuna contra la gripe, what people say is, well, I still get all this gripe when I get the flu vaccine. Great, because you're saying colds, but the vaccine is not against the cold. The vaccine is against the flu. And so we have to be very intentional about the word choices that we make. So I purposely will say, as la vacuna did influenza, right? Talking about the specific virus. Because when we say la gripe, the response is always going to be, but I still got gripe. I still got colds. Despite the fact that I took my flu vaccine, because it's not meant for that, right? And it comes back to, again, what the expectations are that the vaccine can do for us. But I think we have to be very intentional and very specific about the word choices we use, specifically around flu vaccine, because of just that general language issue of how we term it and how we talk about flu versus cold and what that means and what that really will impact.
Oh, that's awesome. Helen, did you have any comment on that?
I
have
think
another question.
for me, one of the things that has helped us is our information, our flyers. We make it very simple. While we love our informational vaccine fact sheet, the letters are this small, has language so complex. Our community has a very low literacy rate. Forget about health literacy. That's a whole other level. And it's very low. So if you don't put things in simple terms, and sadly, we have to put pictures. A picture says 1,000 words sometimes. And I think doing that extra work, because it takes time to take something complex and taking the science and making sure it translates where, my fifth grader could understand it. So I think doing that work, and we did that work, and I think that really helped the uptake increase, because all of a sudden, whether you're getting the flu shot or the COVID vaccine booster or the booster or the vaccine overall, you're starting a new series. Having that information in common language helped a lot.
Yeah. So what I hear, and for those listening, what I hear is that, in simple, digestible terms that are accurate, simple, and also for certain communities, in the language that makes it clear and more specific and intentional, as Dr. Kusher said, and as Helen mentioned, the utility of pictograms in terms of extending the message. It doesn't have to be complicated, just simple, but understandable. And that age group, I think that's very important. Those are great points. Somebody mentioned, how do we address the younger population saying that they do not need this flu vaccine or COVID vaccine? We oftentimes think we are invincible. Thoughts on that?
My young people. I think one of the things, and Kusher, I think we did this together. Didn't we have a youth fair together when the pandemic, or when the COVID vaccine was open to teenagers, when it was 12 and over? We had like a teen event to come and, because dealing with the teens is a whole other, they're mini adults, and I appreciate they're young, and I have a teenager myself.
I have 3.
Invincible.
Yeah.
But I'm like, okay, you want to stay invincible? You need to take this vaccine. And also teenagers, I want to say adolescents, you got to walk the talk, because they're going to be like, well, did you take the vaccine? Show me your card. And don't be offended by it. But like, okay, look, here's my card. And I think, and peer-to-peer. I think one of the things that works really well with adolescents was having this specific event for teens, but also peer-to-peer. I have to tell you, my son, not only because he's my son, but he got his best friends to get the booster right now. He plays football, American football, and he got the Bavarian booster. He was like, what do you mean you didn't get it? I was like, we play out in the cold. And 5 of his teammates came to Elmhurst and got the booster shot. And again, it's that peer education. I'm not sure what he told them, but it got them in the door.
Yeah, that's awesome. That's that peer-to-peer critique, and it makes them join. Dr. Kusher, did you have anything else to add on that?
I think the more in medicine, a lot of us, and Dr. Dan, I'm sure you remember this in medical school residency, we were told to not personalize things, right? That we're the physician, this is the patient, and we have to have a professional relationship. Well, I've always rejected that, and I say that you have to personalize it. When I'm speaking to parents, I say, my kids, I do the following for my kids, which is why I'm telling you to do for your kids. Or I told this for my parents, this is why you should do it for your parents or my cousins or whatever. The more personal I can make it, the more relatable I am, the more likely somebody's going to do it. And, you know, you can say it's right or wrong, but that's what people respond to. People respond more to personal stories than they do to statistics. That's why people respond to Twitter and to Facebook and some random person saying X, Y, or Z. It's a personal story. It relates more to them than it does a statistic about the disparities in the COVID vaccination or the disparities in the number of hospitalized people. It's my cousin, my brother, my uncle's brother's cousin's monkey's uncle did the following, and that is more persuasive to somebody than giving them a statistic about 4 times greater risk of ICU hospitalization for a brown or black person who gets flu or COVID.
Yep.
I'm not really sure why, but that's the power of the personal story.
Yes.
So the more personal that we can make it, the more likely we're going to reach even the adolescent or the young adult who's 18 to 21 and says, I don't need anything, I'm never going to die, or if I get it, I'm going to be fine, So we have to try to make it as personal as possible. And that, I think, does help, doesn't seal the deal per se, but it does help make it so that there's more thinking about it.
Yeah, I appreciate that. I think those are solid answers. There are 3 main highlights there. The personal story, the peer-to-peer. So let actually maybe someone in their age group actually talk to them. So we need to educate that younger population or generation so they're empowered to be able to share that information with their peers. And also we have to walk the walk and talk the talk. We have to be credible and non-judgmental when it comes to them, and give them the option, give them choices. I think those are all important, so they have their own autonomy. At least they feel like that. So those are important answers. There's another question. Can family members be especially helpful in the Hispanic community to promote vaccination? I think that kind of ties in with what we talked about. I mean, really just tasking them and them seeing the stories. I'll use the moderator prerogative to kind of include when we also do these myth bustings. We get the WhatsApp aunties and uncles from all different cultures. We all have them, and I have them in my Nigerian cultural family, and they send it, hey, did you see this? Did you see this? And they send me something, and they're like, yeah, I see it. What do you think? I mean, what do you think I think? I'll tell you what I think. And that's how we kind of dispel it, but it keeps going in the circle. Then I get another video or another story or another thought that, oh, could it be this? And you have to, so there's patience, there's perseverance, there's understanding, and it's all out of love. So I think those are all important. Any other last thoughts as we wrap up, or other questions that maybe we didn't address that you think we should highlight for people who are listening, in terms of our flu and COVID, a vaccine uptake, and education around this whole issue? I think we've talked about a lot.
No, and I love that story about getting because I get a lot of stuff from my family via the WhatsApp, and again, it's seeing it, and I never judge them. I'm always like, oh, I'm happy you're listening to some type of health, anything, but let me tell you why that's wrong information. Or here, if you don't believe me, believe the Surgeon General or Dr. Fauci, which is like world famous. Sometimes I go as simple as Padre Tomas didn't say that. Sometimes, they're just like God. And I'm like, okay, God gave some scientist somewhere the inspiration or to create the COVID vaccine. I think the other thing that it's important for our communities to know is that this is not going to go away. sadly, and I know Dr. Kusher, when we've had our downtime to just decompress, I think our whole community is on this like, okay, we just have to make it to the finish line. It's almost over. It's almost over. And I have to say personally, I don't like any news that says, oh, the pandemic is almost over. I like to think we're in a recovery stage of getting back to a normal or new normal community and health. But COVID is not going to go away, and neither is the flu. The flu has been around since 1918, or even before that. No, I don't think it's not gonna go away. It's something we just have to live with. It's a new disease. Just like HIV and AIDS never went away, COVID is not gonna go away either. So we have to make a choice as a community, and that we have to continuously educate.
I think that's a great point, Dr. Kusher.
I think we just need to remember that as COVID becomes more contagious, in some ways it does become less virulent, meaning it becomes more contagious, but less deadly. However, the long COVID part of COVID is still the part that scares me the most, and the part that separates it from a cold, right? COVID is coronavirus, right? Coronavirus, there's lots of different coronaviruses. A lot of coronaviruses just cause the common cold. The difference about COVID-19 is the long COVID and the symptoms that keep going. Even when you're not contagious anymore, your body is still fighting it off as if it's still there. And that's the part that's the most worrying, and that's the reason why it acts differently, and why the vaccine is still needed, and why this is not over, and it's not going to be over in the sense that that component, which other viruses do have, but not on the same scale of contagiosity that COVID-19 does, and on the persistence that COVID-19 has presented itself with.
Yeah, no, I totally agree with all of that. And I would just, in addition, that's where I was going with that, the whole long COVID piece, with regards to all the symptoms different vague symptoms that people experience. We'll be smarter 5 years from now. We know more, but also at what risk. So, you want to protect yourself as best as you can. So this comes back to the hand washing, the basic public health measures, the wearing the mask, the social distancing. And I think, as I've said, and I've said it in many media outlets, I think we're at the point where we as individuals and our community members can now make educated decisions, understanding we know the playbook. This is what you're supposed to do when we have a virus or we have something contagious or something spreading. And I think we need to educate them on that, the long-term piece that we don't even know yet, because, I don't want to end on a bad note, but I think we need to understand those risks. Is it debilitative disease, chronic joint pain, chronic fatigue, chronic weakness, lack of smell for ever in people's lives, all the other different symptoms that we're finding, people also developing clots later on in life, or months after an infection has resolved. We're still learning, so we need to be humble, and we need to also make sure people understand these risks of reinfections. There's more data coming out on people who actually get reinfected over time in terms of their exponential risk of hospitalization and death. That paper is going to be published. So I give you that as a peek behind the veil of what the risk of long COVID is. We're still learning. So do what you need to do now to protect yourself. And I think that's important. Were there other things that anybody else wanted to share? I think we've covered a lot of ground. We did everything from the racial disparities to how we communicate, to being intentional with our communication, to making sure that for different populations, our teens, that they are, peer-to-peer checking one another, and that may help assuage them into getting the vaccine and protecting themselves, and also understanding risk, our preventative measures, our elderly population, why we should be vaccinated, and why we in the medical community also need to communicate better and temper expectations and be accurate in terms of those expectations. People will get sick with or without the vaccine, but the risk without the vaccine is higher, and the risk and the outcome. So we have to understand benefit risk ratios. We talked about disparities. So I think we covered a lot of ground. And then also maybe there's some strategies. How do we help other clinicians in terms of their surging in their hospitals and their clinic, I think is probably something we didn't talk about. And maybe somebody wants to shed some light on that, how you quickly were able to, while we have a shortage of staff in healthcare, you know, people are leaving healthcare, and how you managed. Is there maybe some quick little strategies you want to share with us in the few minutes that we have left? Anyone?
I'll go quickly and I'll go to Helen. You know, what we have done is we have separated out patients that are coming in with symptoms of COVID or flu or RSV. We have a separate part. We have separate providers that are seeing those patients, filled in with other people to help take on the load. But daily, we're having a separate team that is just addressing those patients. I have a healthcare center. We have 18 rooms. We devote a certain number of those rooms to seeing respiratory patients to try to make sure that we're able to steer those patients and keep the other folks who are not necessarily coming in sick from getting sick, even with wearing masks. And to make sure we can do that, and then devote a certain number of resources, share those resources just within that one section, and then have the other resources shared amongst other providers.
Awesome. Helen?
The shortage of nursing, radiology techs, of medical assistants, of attending, amazing doctors like yourselves, you know, it's something not only felt in New York City, but throughout the nation. And I think the workforce that's coming through our doors is also very different. Sadly, we're going through the great resignation where a lot of amazing staff is leaving. And I can't tell them to stay because they're just like, we did our years of service. We did the pandemic, actually 3 pandemics already, if you count monkeypox. And they're, you know, they want to start a new path. So I can't really hold on to them. But I think the only thing I could do is really create an environment that people enjoy working at and create an environment where they feel they're having an impact on the people they're touching every day. Because the work we do every day is not easy. You know, we're dealing with people who are super vulnerable, who are very ill and, you know, need help. And sometimes when we ask for help, that we're not the nicest people on the planet, but yet we need to hold someone's hand and tell them it's going to be okay. Take them to an OR, help them become on their recovery path, so they can go back home. And sometimes that recovery path is not an easy one. And, you know, doing that work is not easy. Sometimes it's long hours, you know. The hospital is open 365 days, 24 hours. We'll miss Christmas. We'll miss certain holidays because we're here taking care of the communities that we love. So creating that environment is the best thing I could do for right now, because until we get more people graduating med school and PA and nursing school, it's going to take a minute. But until then, what I try to do best here at Elmhurst is create an environment where the staff feel safe, they feel engaged, and they feel they're having an impact on the mission. So
Yeah.
That's what I would tell leaders to work on.
I think both are great points. With that, we've run out of time, so I'm going to pass this on to Laura Lee and close us out, and also, you know, tell us about what's upcoming and the sessions that we have coming. We will do more of these and hope this was useful for the audience. Thank you both for your time, Dr. Kusher and Helen. This was definitely insightful and useful. I think definitely beneficial and had me thinking about some other things too. So with that, Laura Lee, on you.
Well, I'm just going to thank all 3 of you, amazing people. And I'm glad you ended, Helen, with the wisdom of celebrating the staff we work so hard and letting them be a part of the mission, because that's what motivates the 3 of you. And we're very lucky to have you. We're going to have this conversation next Thursday at 11. But it's going to be conducted in Spanish. So if there are folks that you think would definitely get more out of a conversation in Spanish, please do look for the link that will be sent out. And we also have resources on our NMQF SHC website in Spanish and English. So please don't hesitate to go to our website to find them. But most of all, thank you, the 3 of you. It's an honor to work with you. Thanks for everything you're doing. And have a great day, everyone, and a happy new year.
Thank you. Take care.